The agenda this week looked at Ontario's pandemic response, the future of virtual healthcare, and declining male fertility. We begin with the state of kids' mental health.
What do you think has been the most damaging risk for kids, both now and in the long term?
The most damaging thing is really hard to distill because I think this is like a complex chronic stressor that not just kids, but we're all experiencing collectively as adults. And in the context of that, what I've seen and heard with the young people that I work with really are two main concerns. The first is how this has affected learning. Now, there's no one size fits all. Everybody's different. Some people are actually thriving and doing okay. So we have to resist overgeneralization. But there are many young people who are really struggling with distance learning. They lack the kinds of individual supports that they need, particularly young people who might struggle with attention or learning difficulties already. And that's leading to further deterioration in their mental health. The other group are people who struggle with situations where there's high degrees of conflict in their home and they're feeling stuck. They're feeling like they don't have an outlet. And many of these young people, like was said earlier, are struggling with hope. And that's really what keeps me up at night, is that sense of dread and hopelessness, which is important for us as adults to help counter by sharing hope and spreading hope wherever we can.
Sherry, can I just follow up with you because you mentioned hope as well? Is
Mhm.
is the loss of hope related to they think this pandemic's never going to end, or what is it?
I think it's probably quite multifactored. I think it is the idea that it's not going to end. The end doesn't seem to be in sight anytime soon. And I think it's just what others have mentioned around the loss of their peer group, their social supports, their extracurriculars. And I'm still hearing from many that the expectations aren't changing. They're still expected to do well at school, get their A's, attend class. And I think there's a real imbalance between what they're going through and how they're functioning and what's being expected.
Well, we should still, well, I should ask, I shouldn't assume. Should we not still expect kids to get good marks?
I think we can hope that they will, and I think when the moment's right, we can expect them to. Yet I think it just feeds into that pressure that I was speaking about a few minutes ago. Many of the kids I work with and that I'm hearing about from colleagues, they're happy if they get out of bed in the morning and eat breakfast. That at this point, especially in the late end, the end of the school year, they're completely exhausted. They have no enlivenment, no fulfillment. There's no spontaneity in their day. They are just dreading every minute of their day. So I do think that we have to listen to them and we have to dig into their experience and what they're going through. And I do think the expectations have to settle down a little. I think we've got to take our foot off the gas pedal.
Now, Kathy, I don't know how to ask this well, so I'm just going to ask it, and it will be inelegantly asked, but you'll get the drift of what I'm talking about here. Of course, the kids that the three of you are dealing with are, having among the toughest times in the country. Do you think they are reflective of the entire, say, under 18 population right now?
It's a great question. And we are speaking to kids in every province and territory. So I do agree that the sense of hopelessness, isolation, fear, there is a lot of fear we're hearing from kids across Canada right now, afraid for their own health, for their families, for well-being. I also agree that the isolation is creating different dynamics within the home, and the expectation day to day is really stressing our kids out, and we hear it every single day on our platform. So, answering to your question, this is a national crisis that we are seeing, and I also want to make sure we remember that what we're going through now, and I do see a lot of hope actually from the young people that reach out. And the hope I see is that they are reaching out, that they are learning help-seeking behaviors, and they continue to do so. That is a really good resiliency coping mechanism that we are seeing at Kids Help Phone. What we worry about is the trauma that is coming from this past year. And let's remember, it's not just COVID, and it sounds weird to talk about just COVID because it's been pretty traumatic. But in there has been the shootings in Nova Scotia. There's been huge unrest around social injustice And we saw major spikes on our platform around the murder of George Floyd and all the issues uh, around social justice. So I am incredibly worried about this year, next year, the year after. And if we forget this trauma as a country and as a governments, we will have let our kids down.
Last week, we saw two pretty significant developments happen. First, the Auditor General, who is a neutral arbiter of things at Queen's Park, she came out with a report. And then the Premier's own appointed long-term care task force gave its findings as well. So two big reports coming out. And I guess I just like, Jeff, I know you've written a lot about this. I'd like you to just weigh in and tell us what you think some of the, I guess, one or two most important takeaways from those reports were that we should know about.
Well, I guess the main takeaway is that problem of the long-term care cannot be addressed or resolved at all until we put an awful lot more money into the system. It's got to be done. Got to, I guess, start with long-term care homes. Get rid of all those wards. Everybody in the long-term care needs to be in a private room with a private bath. That means rehabilitating all of the older multi-room ward systems, all of the older rooms, and tearing down a bunch of them, which is going to be terribly expensive. I think we've got to do something about the inspection system, which has been a farce, frankly, and is cut back more by the Ford government. No government has paid a whole lot of attention to proper inspection of long-term care for decades. It's been worse recently. Inspectors don't go out frequently when they should. They have a system of notifying the owners and operators of long-term care before they come, so people will quickly bring in temporary workers, so it looks as though they've got more staff than they have. And they don't. They find things wrong. They don't follow up and chase it down. And if long-term care facilities are constantly violating the regulations, nothing happens. So if there are better inspections, that would help a great deal. But I think over the long term, Steve, what you really got to look at is shifting the emphasis away from institutional care, like long-term care homes, and getting more and more into home care. Take care of people at home. Keep as many as you can out of long-term care. They'll do better at home. Their chances of survival are better. They'll enjoy a happier life. And what's the average? They say somebody goes into long-term care, they're dead on average within 2 years. I think this is a lot better, survive a lot better if they can stay at home, closer to family, with regular care coming in to look after them.
Every poll I've seen says people would prefer to live and, frankly, to die at home as opposed to in institutional care. Laura, as you talk to people in the provincial government, clearly the long-term care system has been treated as, in some respects, like a poor second cousin in the healthcare family. Based on your conversations, based on your reporting, do you see any determination in the current government of Ontario to do something about all this?
Well, I think what we've seen throughout this pandemic, and particularly with the release of these reports, is just how completely sidelined the long-term care sector was, how unprepared they were. They were cast aside, and the stories coming out of the Commission's report are just devastating, and frankly, like they're hard to read, and they really pull at your heartstrings. They are so sad, the way that these staff would cry outside homes, the way these people died alone without family. It's seriously disturbing. I think that the Ford government, throughout this has seen how damaging this has been for them, and they are trying to do something about it. And we've seen many announcements about homes to be built and good news announcements in their minds. I mean, the trouble is that these are years, if not decades away. And the Ford government does have to answer for, as the professor mentioned, the lack of comprehensive inspections, why there was no preparation between the first and second wave, which I think the public views as inexcusable. And the minister has to take some responsibility for this, and we've seen a real resistance on her part. So yes, I think there's certainly a recognition that this needs to change and that there needs to be infrastructure built, but also the commission talks about a wholehearted change in the way that the sector is run. While profit could play a part potentially in building these homes, that shouldn't be the sole purpose of running a long-term care home. So there is a lot of soul searching that needs to be done now. And I think this is going to be one of those major issues that dogs the government heading into the next election.
To that end, Dr. Collins, do you think there is a concern of virtual care being seen as somehow the default kind of care that is provided, and doctors in the future might only actually see their patients in person on rarer occasions?
Well, certainly, Steve, CMA's view on that is that virtual care is never meant to replace in-person care. It's meant to be complementary, and ideally it should be used where there is an established doctor-patient relationship. Certainly, I think that you make a good point, and we are only going to see an explosion of further devices, artificial intelligence, other adjuncts to virtual care that will be able to expand its use. But no, at the end of the day, when a person presents with a problem and you can manage it so far, perhaps with virtual care, there should be someone at the end of that care relationship that can actually see the patient. There are times when you know that you're not making the mark, you're not hitting the mark, you're not knowing what's wrong with this patient. You have to see them, you have to bring them in, you have to touch them, you have to lay your hands on. And of course, there are many other things that we currently provide as services in primary care, like immunizations and other screening procedures that need to be done in person with contact.
Dr. Affleck, let me try this with you. Are there safety concerns around the use of virtual care?
In short, yes, Steve, there are safety concerns. And there are safety concerns with any use of technology in healthcare. So we have to be very prudent with that. A very simple way to look at it is that a lot of issues happen between the interface in care. So if you see your family doctor and they refer you to a specialist, or if you're seeing a rehab person or you're going for surgery, the interface between those services, if information is lost, if lab results are lost, x-rays, whatever, communication of any sort is lost, then the individual caring for you will have less information on which to adjudicate your care, and potentially errors can be made, or your care may just be, you will not get the follow-up you require, right, for something that is time sensitive. So virtual care by definition involves the use of information, or the transmission, exchange of information between services and individuals. And so we have to ensure that that occurs in a way that assures the integrity of the information. Otherwise, it can be unsafe. And I will just finish this statement by saying there's not a long tradition of evaluating the safety of these technologies. We evaluate them with respect to privacy and security, but not safety. So this is something as a collective in Canada we need to begin addressing.
Let me follow up with Dr. Thompson on that. Are you concerned that virtual care opens the door for more examples of misdiagnosis?
I think there is that potential. I think part of what's being discussed here, and certainly Anne referenced this, and Ewan as well, is that these technologies work best in existing relationships. So, we have the advantage of knowing our patients well, but certainly we need the whole story. And so one of the dangers is if there's episodic care, whether it's virtual or face-to-face for that matter, at a walk-in clinic, not having the full background on the patient can really pose some serious issues. So, this will be the challenge going forward, is the types of clinical encounters we have, or the types of problems. For example, acute chest pain, not appropriate, right? As it might be a triage encounter that you have, but really that person needs to be seen urgently at hospital. I do know of one case apparently that went off the rails. It was apparently a necrotizing, a pancreatitis. Patient presented with abdominal pain. It was a virtual encounter, and the physician was found, unfortunately, to be responsible for not managing that appropriately. It was disciplined. It should have been triaged to the hospital. Now, that being said, that's a diagnosis you could miss in your office and putting hands on the abdomen and feeling. So, part of this involves what sort of relationship we have with the patients. They have to trust us that we're doing the best for them, but we also have to make sure that if we're thinking of a more serious diagnosis, what's the best way to triage and deal with this, right? And it may mean disengaging from the virtual and going to a deeper encounter that's going to be a face-to-face in hospital or in clinic.
Here are some numbers and a quote from your book to get us started. In 2017, you examined the findings from 185 studies involving nearly 43,000 men that had been conducted over a 38-year span. And you found that between the years 1973 and 2011, sperm concentration, in other words, the number of sperm per milliliter of semen, dropped more than 52% among random men in Western countries. Meanwhile, the total sperm count fell by more than 59%. And you write, the current state of reproductive affairs can't continue much longer without threatening human survival. Now, that all sounds extremely alarming, but genuinely, how concerned do you think we ought to be?
Well, obviously, I'm concerned because I wrote that, and I feel that the current state of reproductive health is really pretty serious. And the number, when we last looked at the sperm concentration, there were 47 million sperm per milliliter median worldwide. So that number dropping from 99 in 1973, that's a huge decline. And what that means is that at 47, we're very close to 40. So 40 million sperm per milliliter sounds like a lot of sperm. It is a lot of sperm, but it turns out that when a man's concentration drops below 40, then a lot of things kick in. His probability of conceiving goes down. The number, or the per cycle pregnancy rate goes down, and actually he himself experiences an earlier age of death because there's a lifetime consequence of this poor sperm count. So now that we are arguably at around 40, because that, if the decline continued, which we don't know yet, then we would certainly be below 40 million per milliliter, and in that area of impaired fertility. And so with a lot of the world in that place, and seeing the increase in assisted reproduction, decreases in total fertility rate, I believe that we're in a serious problem.
This is a problem in the developed world. Is it also a problem in the developing world?
We have much less data, much fewer studies from developing countries. That's because these sperm count studies take a certain level of technology and sophistication, but we're getting more of them, and we're hoping in an update that we're doing, we'll get more information. But the fertility decline, which is the number of children born per woman, that has been worldwide at about the same rate. So the total number of children born in 1960 was 5 per woman or couple worldwide, and that has dropped to 2.4 worldwide in 2019. So that's the same roughly rate of decline in fertility and sperm count, and it is worldwide for fertility. It's going on in every country, and many countries, particularly Western countries, are now below replacement. So this is not just a Western problem.
The thesis of this conversation now having been established, let's bring our other two guests in here and get some reaction from them as to this information we've just received. Linda, why don't you start us off here? Shauna has written that this is a global existential crisis. What do you think?
I tend to agree with Shauna. About 15 years ago, there was a movie some people may remember called Children of Men, which posited that there was extremely low fertility and it was a huge problem. I think that that is, for the world, I'm not sure overall, with well over 7 to 8 billion people on our planet, I'm not sure that fertility is a problem when you look at it that way, but when you look certainly at an individual couple or individual people, it is a problem. And I think that the data is growing and extensive, that it's not only male fertility, which has decreased, but also female fertility as well.
Richard, what say you?
Well, I think there's a major problem with male reproductive health for sure. I think that the global reduction in couple fertility is an issue where we have two factors at play. The one that we're concerned about now, which is adverse changes in sperm counts in men, and thus in couple fertility, and societal changes, which have had a huge impact on couple fertility when they're trying for children, and also how many they want to end up having. So it can be difficult to disentangle those two. But I think that the biggest impact of having lots of men with low sperm counts is another societal change, and that is the delay of couples in trying for children until the female partner is in her 30s. That's becoming now almost the most common situation, because at that time, fertility in the female is much reduced compared with when she's in her early 20s. And that means that sperm count becomes a much bigger player.
Let me read something that was recently published in the New York Times, and this will highlight one word in particular, and that word is languishing. Languishing is a sense of stagnation and emptiness, and it might be the dominant emotion of 2021. It is the neglected middle child of mental health. It's the void between depression and flourishing, the absence of well-being. You don't have symptoms of mental illness, but you're not the picture of mental health either. You're not functioning at full capacity. Languishing dulls your motivation, disrupts your ability to focus, and triples the odds, that you'll cut back on work. It appears to be more common than major depression, and in some ways, it may be a bigger risk factor for mental illness. As soon as I said the word, you said, oh yeah. So I gather this is not news to you.
No, this is, it's an interesting fact. One of the things that often happens in new situations, pandemics, is things that we know about get given new labels, and those new labels get some currency. And that's not to say it's wrong. And the fact that people identify with the word languishing, I think, is very important. But the description of languishing seems very similar to the description of mild depression, mild anxiety. And it would be interesting to know whether you can differentiate the two. The important thing about it is some people say, well, this isn't important because it's not a serious mental health problem and it doesn't need medical intervention. And I would say, well, you're right. It doesn't possibly doesn't need medical intervention, but it is an important problem. If we in a thought economy, in a service economy, in the economy we have, we need people to be bright-eyed and bushy-tailed in order to push forwards. If we want to build back better, we all need to be on our A game. And languishing, which is mental distress, which is mental I can say not mental, is mental ill health. I didn't want to say that because it sounds so crummy, but it's certainly not well-being. It's going to be important. We have to have a strategy to deal with it. That strategy may not be a medical or clinical strategy, but it may be online strategies. It may be that we have to think about equipping each other with the ability to work through it. But it is going to be important that we deal with it. Interestingly, one of the things that I saw on the Statistics Canada website was the impact of the CERB on mental health and mental distress. And you can see a decrease in mental well-being in Canada as the pandemic started to roll out. And you can see the impacts, particularly on low-income groups. And then as the CERB was rolled out, you can see that a significant uptick in mental well-being, and I would imagine also decreasing the amount of languishing that was happening in Canada. So when we're thinking about what we're going to do about languishing, we possibly have to think about how we can equip ourselves. We possibly need to think about what advice we can give ourselves to be more mentally healthy. But we also have to think about the situations we find ourselves in, or we put people in, and think about what we can do to decrease the worries and decrease the stress and give people the opportunity to work through what is a very difficult and traumatic time for a lot of people.
That's just some of what we covered this week on The Agenda. For more, including the full conversations, you can visit our website, tvo.org, our YouTube channel at youtube.com/theagenda, or our Twitter feed, twitter.com/theagenda.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.